All right, welcome to The Explainer. Today we're doing a bit of a masterclass, really honing in on one of the most vital skills in all of medicine, the cardiovascular exam.
You know, we live in this amazing era of high-tech imaging. We've got echoes, CTs, cardiac MRIs, you name it. But here's the thing. Before we even think about ordering any of those, there's one tool that's still the absolute cornerstone, the physical exam. It's not old-fashioned, it's essential.
So you gotta ask, why does it still matter so much? Why do we spend all this time perfecting it? Well, think of it this way. A really good exam turns you into a clinical detective. It's your first and honestly your most powerful move. It's where you find those first critical clues that point you in the right direction.
Okay, let's get into it. This isn't just a fancy title. The exam is the foundation because, well, it doesn't cost a thing. You can do it right now, and it gives you a live, real-time snapshot of what the heart is actually doing. You can literally form a working diagnosis right there at the bedside. So, where does this whole investigation start? It always starts with listening. A patient's symptoms, they're not just complaints, they're precise clues. Our job is to be the expert decoder for the story their body is trying to tell us.
All right, let's tackle the big one, chest pain. This is probably the most common and, frankly, the scariest symptom we encounter. The first question that has to pop into your head is this the heart? And you know what? The answer is usually hidden in the tiny details of how they describe that pain.
Okay, look at this. This table is just brilliant at breaking down the life threats. So, if the patient says it feels like pressure or tightness, and it happens when they exercise, you're thinking angina. But what if they say it was a sudden, tearing, or ripping pain? Whoa! Your brain has to go straight to aortic dissection. And then there's the sharp, stabbing pain that gets worse when they breathe in, but feels better when they lean forward. I mean, that's textbook pericarditis. See? The quality, what sets it off, what makes it better. These are the clues that separate the diagnoses.
Next up, dyspnea, or, shortness of breath. And this is key. It's not just one thing. It's like a whole language. If they get winded just from walking a bit, that's exertional dyspnea, a classic sign of left heart failure. But what if they tell you they need 3 pillows to sleep, otherwise they can't breathe? That's orthopnea. Or maybe they wake up in the middle of the night totally breathless? That's PND. And this newer one, bendopnea, getting short of breath just from, say, tying your shoes, is super specific. Each one of these paints a clearer picture of fluid backup and a struggling heart.
Syncope, fainting, is another one that really gets your attention. And with fainting, context is everything. I mean everything. Someone passes out during exercise. That is a huge red flag for some kind of blockage, like severe aortic stenosis or HCM. But what if they just suddenly pass out, no warning at all, just sitting down? That screams electrical problem, a dangerous arrhythmia. See how the story they tell you completely changes what you're going to do next?
Okay, so we've listened, we've decoded the story. Now it's time for the hands-on part of the exam. We're shifting gears here from what the patient feels, the symptoms, to what we can find, the signs. We're literally going to read the signals the body is sending out through the pulses and the veins.
The jugular venous pulse, or JVP, I gotta say, this is one of the most elegant, coolest parts of the entire exam. Just by looking at the neck veins, you get a direct window right into the right side of the heart. It tells you about the pressure, how it's functioning. It's seriously like having a non-invasive central line right there at the bedside. It's incredible.
And one of the most dramatic things you can see is something called a Cannon wave. Just picture this. The right atrium gives a powerful squeeze to push blood forward, but bam! The tricuspid valve, the door to the next chamber, is slammed shut. So where does all that pressure go? It has nowhere to go but backward, up the veins, creating this huge, booming pulse you can actually see in the neck, a Cannon wave.
So what on earth would cause the atrium and ventricle to be so out of sync? Well, the causes are really serious. We're talking about life-threatening arrhythmias, things like complete heart block or ventricular tachycardia. So if you see a Cannon A wave, that's not a subtle clue. That is a 5-alarm fire. It's a bedside sign that you're dealing with a major electrical emergency right now.
And it's not just the neck veins. The pulse in their wrist, the arterial pulse, can tell you so much. If you feel a pulse that's weak and slow to rise, we call it parvis et tardis. Your first thought has to be severe aortic stenosis. If you feel the pulse alternating between strong and weak beats, pulsus alternans, that's a sign of a very weak left ventricle. And then there's pulsus paradoxus, A big drop in blood pressure when they breathe in. That's a classic sign of cardiac tamponade. I mean, think about that. Your fingertips can basically diagnose these huge conditions.
All right, now it's time to grab the stethoscope. We're going to listen to the heart. But here's the key. This isn't passive listening. We're not just waiting to hear something. We're going to interrogate the heart. We use these dynamic maneuvers to challenge it, to make the sounds and murmurs give up their secrets.
Let's talk about those extra heart sounds, the S3 and the S4. An S3 gallop is this low-pitched sound you hear early in the filling phase. People say it sounds like Kentucky. In an adult over 40, hearing an S3 is a big deal. It means high filling pressures, a key sign of heart failure. Now, the S4 is different. It's late in the filling phase. It sounds like Tennessee. That sound tells you the atrium is kicking like crazy against a really stiff, stubborn ventricle. You hear that in things like long-term high blood pressure or aortic stenosis. So you're listening and you hear a systolic murmur. Okay, but what is it? Is it something innocent or is it something dangerous? It can be really hard to tell. This is where dynamic auscultation is an absolute game changer. We can actually do things at the bedside to make that murmur speak to us and reveal where it's coming from. And this slide shows the power of one simple trick, the Valsalva maneuver. You just have the patient bear down like they're straining. What does that do? It reduces the amount of blood coming back to the heart. And because there's less blood flow, almost every single murmur gets quieter. But, and this is so important, there is one major exception. The murmur of hypertrophic cardiomyopathy, or HCM, actually gets louder. This opposite reaction, it's a classic, absolutely vital clue that helps you nail this very dangerous diagnosis.
Okay, so this is the final and maybe the most important part, the art of synthesis. This is where we put on our detective hat again. We take all these separate clues from the patient's story, from the JVP, from the pulse, from what we heard with our stethoscope, and we weave them all together into one single coherent story that makes sense.
And just look at how beautifully these pieces fit together. You hear an S3 heart sound, that points to high LV filling pressure, which leads you to congestive heart failure. You feel a pulsus paradoxus and see an absent Y descent in the JVP. That tells you the heart can't fill properly, and that leads you straight to cardiac tamponade. Or you hear a fixed split S2. That's a super specific sign of a constant shunt, an atrial septal defect. See, it's not just one finding, it's how they all connect to build an undeniable case.
So what's the big takeaway here? What do I really want you to remember from all this? It's simple. The clinical exam is the foundation, period. Everything else is built on top of it. Your bedside findings give you direct insight into what's happening with the heart's plumbing and electricity. And those fancy, expensive imaging tests, they are incredibly powerful, but their job is to confirm what you already suspect. They don't replace your brain, your hands, or your ears. They work with them. And I think it's only fitting to end with this quote from the great Sir William Osler. Listen to your patient, they are telling you the diagnosis. It's just the perfect reminder, isn't it? That with all the amazing technology we have, the most powerful diagnostic tool we will ever possess is a pair of listening ears, a thoughtful mind, and a careful, well-done clinical exam. That's where the magic really happens.